was a prospective study, and a prospective study means they started enrolling patients and then following them. So as opposed to a retrospective study where they looked backwards. So this was a prospective study looking at over 8,000 adults. They had to be at least 45 years of age or older. And then they compared sedentary time, so time sitting or doing nothing, versus light intensity physical activity or moderate to vigorous intensity physical activity. And they put them into groups. So group one, thanks. Okay, so tertile one or group one had the most activity, the least amount of sedentary time. Group two had the medium amount of sedentary time, and then group three had the most sedentary time. The first graph being total sedentary time, and then the second graph just being the mean or the average sedentary time. And they followed these patients for 7 years and then looked at overall cancer mortality. And you can see that the higher the curve, the more people that passed from cancer. And it was very directly linked to the amount of sedentary time. So I think there was a study that came out a year or two ago showing, sitting is the next smoking. And so we really want to stay moving and making sure that we're incorporating exercise into our daily lives. This is just another way of looking at it. And you can see that, interestingly, there was even a benefit. So if we decreased our sedentary time down far enough, we actually had an improvement. So the hazards ratio became negative, which meant that there was actually a benefit or a reduced overall mortality. So this is total sedentary time hours per day, did not count sleeping time. So that is obviously sedentary time, but does not actually count. So you can see that the more you sit around, so if you have 15 hours a day of sitting time, you can double or even almost quadruple in some patients the risk of death. So the more we can move, right? So then, let's see, there was another study. Oh, so what the conclusion was that just replacing even 30 minutes of sedentary time with 30 minutes of light intensity physical activity was associated with an 8% decrease in mortality, and replacing 30 minutes of sedentary time with 30 minutes of moderate to vigorous intensity physical activity was associated with a 31% decrease in mortality. So really anything you can do can help, but maybe the more we do some moderate to vigorous intensity activity, the better. This next study, which was published in 2019, looked at sedentary behavior with cancer mortality, but also with cardiovascular disease mortality. And they were wondering if sedentary or if the association differed at all by level of physical activity. So not just how many hours of sedentary behavior, but can it be modified? So what they did is they looked at total sedentary time, both sitting time and TV time, but in the context of the level of physical activity of the person. So they divided the sitting time into 4 groups: sitting less than 4 hours, 4 to 6 hours, 6 to 8 hours, or over 8 hours. Then they grouped TV viewing in different groups: less than an hour, 1 to 2 hours, 3 to 4 hours, over 5 hours. And then they looked at 4 physical activity groups, and they classified them as 2.5 MET per hour or MET hours per week. And that was equivalent to about 5 minutes a day of medium to vigorous physical activity. they looked at the 16 MET hours, which was equivalent to 25 to 35 minutes per day of moderate to vigorous physical activity. And then 30 MET hours per week, which was equivalent to 50 to 65 minutes per day of moderate to vigorous physical activity. And then the final group was just a little bit higher than that at 35.5, which was essentially 60 to 75 minutes per day. And what they found was that when they looked by sitting time, so each of these, I don't know if you can see my arrow here, but each of these little bar graphs, dots plus bar graphs, is the different number of hours of sitting. And then each grouping is based on the metabolic expenditure or the amount of moderate to vigorous physical activity. And you can see that as you move up in the amount of physical activity, the excess sitting time or sedentary time becomes less important. So if you are doing 0 or roughly 5 minutes a day or less of moderate to vigorous physical activity, that additional sitting time significantly increases your risk of mortality. But if you are more active, so if you go all the way to this highest activity group, there was no statistical significant difference between the amount of sitting. So even adding additional minutes per day can help decrease or mitigate the sitting time that you do. And again, many of us maybe have desk jobs or other things where we can't get away from sitting a lot of the day, but you can make up for that in your spare time. This was the same thing divided into the 4 groups by physical activity level, but within each group, they looked again at the hours of TV time. So a little bit different than just the plain sitting time. This was TV time. And again, you can see as you move up in the activity level that those lines all cross that 1 bar. And when we have a hazard ratio of 1, that's assuming, baseline, and then anything above or below may be statistically significant. But if the bar graph then crosses that line, that's not statistically significant, although you can certainly see some trends toward worsening. So obviously we shouldn't be spending 5 hours on the TV every day, but increasing the amount of physical activity that you do can substantially reduce the risk. Okay. So moving on to hyperinsulinemia, which is probably my favorite topic. Everybody knows I like to always know what everybody's fasting insulin level is, although fasting insulin is not the only measure. There are a number of people, probably in the 20% range, that have normal fasting insulins, but probably have abnormal responses to a glucose load, meaning that insulin rises too high and stays elevated too low. But if we look at all of the diseases that can have associations with hyperinsulinemia, we can see that cancer is one that is front and center. But it goes along with so many of our chronic diseases. So overweight and obesity, diabetes, cardiovascular disease, stroke, Alzheimer's and dementia, seizure disorders, hypertension, PCOS, polycystic ovarian syndrome, depression, anxiety, hypoglycemia. People don't think about hypoglycemia. They think about it as being undersugared, but it's actually being overinsulined. Migraines, eczema, acne, gout, chronic fatigue syndrome, fibromyalgia, multiple sclerosis, many, many more. If you type into a Google Scholar, which is a way you can search for articles written in the medical journals, and you type in hyperinsulinemia and just about any disease under the sun, you will find multiple studies showing that there is some interrelationship. Why do I care so much about insulin? Well, I care about insulin and its effects on cancer. We know that insulin and its sister hormone, insulin-like growth factor 1, are very important factors for growth. They enhance tumor cell proliferation. If you look at this little graphic, you can see the little yellow receptors on the cell surface, insulin receptor and an IGF-1 receptor. And insulin and IGF-1 bind to those receptors and increase the features that are growth factors. And so I don't know if anybody's familiar with some of these terms, but a very new and more common breast cancer chemotherapy or medication is a PI3K inhibitor. And you can see that PI3K is actually stimulated by insulin, which comes along with sugar. And we know that when we do certain diets, obviously I recommend a ketogenic diet, which is somewhat of a natural calorie restriction, the carbohydrate restriction. We know that we can really limit the signaling of insulin and IGF-1, and therefore we don't turn those receptors or bind to those receptors and start the cascade. When we burn fatty acids for fuel, we kind of stimulate the opposite side, which is actually decreases glycolysis, increases lipogenesis, and it actually has an inhibition on mTOR, which is one of the growth factors. I will go back, sorry, metabolic syndrome. So we've all heard about metabolic syndrome, which is typically in an obese or diabetic patient, but it's defined by hyperinsulinemia, mainly in the combination of central obesity, hyperglycemia, hypertension, high triglycerides, and or low HDL. This is associated with being in a chronic inflammatory state and accompanying cytokine abnormalities. So the adipose tissue can secrete these pro-inflammatory cytokines that leave us in this constantly inflamed state, which actually contributes to tumor progression. So insulin is associated with weight. Insulin is lipogenic, meaning that it creates fat. It is a fat storage hormone. When glucose comes in and there's no storage space, so our glycogen stores are filled up in the liver, in the muscles, then insulin starts to turn leftover glucose into triglycerides and put them into fat cells. When insulin gets turned off, then the body then lets fat come out of the fat cells to burn as fuel. If you're eating more fat, then it will burn that. So if you don't have fat to lose, you can burn the fat that you eat. Some people can overeat fat on a ketogenic diet and not lose body fat because they're just burning the fat they're eating. So when insulin turns on, we store fat. When insulin turns off, we burn fat. And the problem with our current society is that we tend to eat all day long. So we tend to eat higher carbohydrate foods. We tend to have insulin on, not quite 24/7, but a lot. And instead of insulin coming way back down to a nice normal low baseline overnight, when insulin is elevated for so long, so many days, so many hours, so many days, so many years, that it never goes down. So our pancreas is always producing insulin throughout the course of the day. So we never quite go into that fat burning state. So we know that insulin is related to our blood sugar. And if we are eating a high carbohydrate diet, we tend to get bigger spikes in blood sugar, which requires bigger spikes in insulin to get that quieted down. This is my favorite insulin curve, so Kraft patterns. So insulin response to an oral glucose tolerance test or a carb load. The green curve, number 1 being the normal response. Insulin starts low. It peaks somewhere in the 30-minute to an hour mark, and by about 2 to 3 hours, it's back to the baseline. But patterns 2 and 3 that have relatively normal fasting insulins still have quite exaggerated responses. And then number 4 has a very elevated fasting insulin, as well as a significant rise and delayed recovery of insulin. And these curves were all done in non-diabetic patients. So none of these people were considered diabetic. I will guess that, number 4 could have been a pre-diabetic population, although I thought he screened for both pre and diabetes. So, but the bottom line was that in this test, which was done years ago, 1980 something, I think, about 70% of patients still had an abnormal insulin response. So why do I advocate for a low carbohydrate, high fat, or ketogenic diet? Because it keeps blood sugars stable. We're not on a roller coaster, so we tend not to have hyperglycemic or hypoglycemic responses. We keep that insulin and the IGF-1 levels to a minimum. So in a cancer setting, we are minimizing growth factors for cancer. In addition, we're allowing the body to burn fat for fuel. So not only are we losing weight, but we are also lowering the adipose signaling or cytokines that can be released. And when fat is burned for fuel, then fatty acids and ketone bodies are used, they're produced, and the ketone bodies is how a ketogenic diet gets its name. You do not have to necessarily eat a low carbohydrate, high fat diet to be in a ketogenic state. There are other ways to do it. Fasting, significant calorie restriction. Some people can do it on a relative, standard American diet, if they are still metabolically flexible. So maybe a young person or an athletic person, although I will tell you, I've seen many an athlete who don't carry excess body fat, but because they fuel with such high carbohydrate diets that they actually are very metabolically inflexible. Many a marathoner has developed diabetes or pre-diabetes. So it is something that should be looked at. You can't just look at the cover and say somebody's healthy or, they look fine. So it's not about the amount of fat on your body. And there are some people who are still effectively storing fat that their insulin has not started to rise. So there might be somebody that's heavy, that's blood glucose and insulin are still getting down to normal fasting levels, or optimal fasting levels, I should say. But that's not always the case. So what does ketosis means? Or what does it mean? Being in ketosis really is quite interesting. So I don't know how many people, I know probably quite a lot of you are following a ketogenic diet, have been in ketosis, but you realize that it's pretty self-regulating, that you just aren't hungry as much. There are some people who have told me, it's the first time in their life that they haven't been hungry all the time. When weight loss is needed, I will say that many people will have even less hunger because they're actually finally eating the food that they've stored away for many, many years, maybe even decades. So it results kind of in a natural calorie restriction, follows a natural intermittent fasting. When I have somebody that's interested in doing fasting, although we certainly can do it with any diet, I usually say get yourself on a ketogenic diet first, because then fasting is easy. And it's just like anything, you practice it. You might not be able to go too long the first time, but most people transition into a really nice intermittent fasting schedule when they first transition into a ketogenic diet. It also allows for our hormones to function properly. Both our hunger and satiety hormones, but other hormones. It's been shown to help with thyroid function, our sex hormones, and everything else. So it's quite an interesting phenomenon. In addition, when you are in ketosis, your body is actually doing some autophagy or recycling of damaged cells. So autophagy kind of came into vogue maybe 3 or 4 or 5 years ago when there was a Nobel Prize awarded for the discovery, so to speak, of it. And what they found is that 3 days of fasting put people into basically an autophagy state. Well, what does 3 days of fasting usually do? It usually takes somebody who is in a glycolytic burning phase and puts them into a ketogenic state. So if you are following a ketogenic diet, you are already in a ketogenic state. And it's very likely that each night while you're in ketosis, you are actually doing more recycling of damaged cells. So we always are trying to kind of clean house, so to speak. And so being in a ketogenic state allows that to happen far more easily. Being in ketosis increases energy level. I see that all the time, is that if we can finally use the fuel that's on our body that we saved, we tend to have more sustained energy level. We don't have the ups and downs of fatigue. In addition, and it's one of the reasons why this is probably an effective strategy in some of the brain disorders like seizure disorder, dementia, Alzheimer's, is that that's effectively like an insulin resistance of the brain. And when we create ketones, ketones are a very usable and happy fuel for the brain. So it doesn't require insulin receptors. Any ketones that are made are just kind of pushed, so to speak, straight into that brain, and it's used for fuel. And so they've shown that being on a ketogenic diet actually has some repair in the brain. So they've done MRIs before and after ketogenic diets. They've shown that the hippocampus, which is kind of our memory center, actually grows substantially when we provide ketones for fuel. So I wanted to touch quickly on the 10 hallmarks of cancer. And I don't know if anybody's familiar with this, but I'll tell you every cancer doctor is. It used to be 6 hallmarks of cancer, and then it's 10. And in fact, I just saw a recent study that I think they might be adding 2 or 4 more, or considering them. But basically what it's talking about is, what does a cancer cell, or what does a cell, what do they have to gain or have in order to kind of be a cancer cell? It has to have sustained proliferation, because our normal cells, like if we get cut and our skin works to heal and close, right, we grow more skin cells, but it doesn't keep growing. We don't have a football on our arm. We just close the gap and then our cells stop growing. So there's kind of an innate mechanism in our bodies so that our cells only do what they need to do and then they stop growing. So cancer cells lose that function and they can continue to grow kind of unregulated. They start to dysregulate cellular energetics, meaning that they turn on their glucose use and they turn off their fat use. So they lose that mitochondrial Krebs cycle and they go into a glycolytic mode or a glucose burning mode. They resist cell death. So many of our cells, when they get damaged, they will go through an automatic apoptosis, or just cellular death. The cell says, oh, I'm not the cell I was supposed to be, so I will just take myself out. And cancer cells lose that ability. Inducing angiogenesis. So these cancer cells, as they grow, they kind of create their own environment and they grow their own blood vessels so that they can pull nutrients and sugar to them. So again, they induce angiogenesis. Genomic instability. So they, again, affect, we know that there are different mutations in different cancers. So we're losing kind of the normal gene signatures that allow for stability. Activating invasion and metastases. So the cells have to be able to get through a blood vessel or get out of the tumor or the tissue of origin. So let's say get out of a breast tissue and get into the blood vessel or lymphatic vessel, float through that system, get out of that system, and then set up shop in a new tissue and grow there. So that requires quite a lot of ability. We talked a little bit about insulin and adipose cytokines as tumor promoting. So the chronic inflammation or hyperinsulinemia is tumor promoting. They need to be able to replicate in immortality, right? So they just keep growing and growing and growing. Now, if they don't get enough blood supply or nutrients, some of those cells might die. So they don't grow in an exact, 1 to 2 to 4 to 8 to 16. So logarithmic growth, there is some die-off as they grow. But essentially they continue to grow unless we do something to stop that. Evading growth suppressors. So not only are we giving growth enhancers, we're stopping the suppressors. So again, all of this, and then I think I skipped the immune function. So they're basically avoiding the immune surveillance. So we are all cancering every single day. We're constantly being bombarded by toxins in foods we eat, things we drink, air we breathe, you name it, chemicals that are in food, water, clothes, etc. We can't escape, getting damage from our natural environments. But our immune system is supposed to be really good at surveilling abnormal cells and then getting rid of them. And these cancer cells basically avoid that immune destruction. But there's been a lot of research on how might a ketogenic diet actually limit, or ketones, because there is some research also being done on exogenous ketones, or ketones that you can drink, or even on like MCT oil, which is a refined coconut oil that your liver will turn directly into ketones. And can those types of things happen? But what they have found is that ketones have definitely been shown to reduce inflammation, reduce peritumoral edema, so swelling that surrounds a cancer, the inflammation that surrounds a cancer. Ketones have been shown to either inhibit or reduce tumor growth. Ketones have been shown to reduce hypoxia, and it's the hypoxic environment that can protect cancer cells. Ketones have been shown to enhance the effects of radiation, chemotherapies, and hormonal therapies. Ketones are HDAC inhibitors, so histone acetylation or deacetylation. So what that means is that if they inhibit, then they increase the histone acetylation, which decreases the genes responsible for DNA repair, increases radiation and chemo-induced DNA damage. So there is some mechanism by which basically the DNA is unwrapped so that things can happen to it, repair, injury, etc., and then they get wrapped back up. And so ketones enhance, that's how they enhance some of the treatment-related damage. Ketones have been shown to increase the expression of at least 55 microRNAs. MicroRNAs are involved in those 10 hallmarks of cancer. They're involved in the regulation of DNA repair genes and in the regulation of oncogenes. Those are genes that code for cancer. Ketones have been shown to be COX-2 inhibitors, COX-2 being a driver of cancer. It lowers CRP, so lowers inflammation. It decreases reactive oxygen species, which are kind of like the exhaust, from your engine. And so it can decrease that exhaust. It decreases the glucose utilization as well as the glutamine utilization. Those are two fuels that cancers use. It lowers insulin and IGF-1 signaling, which decreases mTOR, again, another growth factor, right? It decreases the PI3K in stimulation. It increases fatty acid utilization, which then increases what's called AMP kinase. AMP kinase regulates the growth and reprograms our metabolism, and it's associated with autophagy. It also increases PPAR alpha, which is anti-inflammatory, anti-thrombotic, lowers triglycerides, it raises HDL, all very favorable changes. So do we actually have to measure ketones? And I usually ask a person, well, what's your goal? Are we just doing it to lose some weight, increase our energy, maybe help with some the most common chronic diseases like prediabetes, diabetes, overweight, obesity, hypertension? And if so, you probably just can follow a basic ketogenic diet without ever measuring your ketones and find pretty good success. I think from a cancer prevention standpoint, that's probably the case. Decrease the risk of recurrence, probably the case. It might depend a little bit on how high risk your disease is. But if you're using a ketogenic diet as an active part of your therapy, like maybe you're a patient with metastatic disease and you've kind of exhausted chemotherapy options, you're using a ketogenic diet to maybe help slow your cancer, or maybe you're using it to augment the active cancer that you have. You're going to use it in conjunction with your current therapies, with radiation or chemotherapy or hormonal therapy. You might consider testing. How do you test if you wanted to? Well, you can measure ketones in a lot of different ways, and I will give you my pros and cons. So urine strips, they measure acetone, which is one of the ketone bodies. So beta hydroxybutyrate, acetoacetate, and acetone are the three ketone bodies that can be measured. Acetone is excess acetone. If you didn't use it, acetone gets excreted in the urine. Urine strips are super inexpensive, and they're a great way when somebody is starting a ketogenic diet to say, yep, I'm making ketones. Doesn't tell us a whole lot more than that. Over the course of years, you may or may not, and I shouldn't even say years, days, weeks, months, or years, you may or may not have positive ketones on your urine strip. If you're really utilizing the ketones that you're making, you may not have excess to excrete. If you are super dehydrated, it might show very high levels when really they're relatively low. So there's a couple of pros and cons to measuring urine. Breath meters are a one-time cost, although quite costly. They are easily portable and gives you kind of an immediate feedback as to the level of your ketosis, but they're not great at giving you true values. So there are some folks that have seizure disorders, and they do use that where they check themselves throughout the day. And if they're on the low end, they might take some MCT or coconut oil or exogenous ketones, because if they come out of ketosis, they actually seize. So they are kind of on a more immediate need. Others will use it kind of as a check-in. Maybe they're traveling, they don't want to take their blood glucose meters, and they just want to kind of check in at various times. Or, it's nice to, carry in your purse if you just want to check when you're in the car, at work, whatever. But not really. I haven't found them to be super useful. Blood meters give you very concrete values. It measures beta hydroxybutyrate. It can also measure glucose, and therefore you can get what's called a GKI, or a glucose ketone index, which may actually provide us more valuable information regarding therapeutic ketosis, meaning are we in a deep ketotic state that is producing enough ketones in a low enough glycolytic state that maybe we're getting some of those outstanding benefits. So I'm just going to review a couple of papers that kind of go over this idea a little bit. So this first paper was a paper that looked at 10 patients with advanced cancers that were essentially on kind of a comfort care. They weren't doing active therapy, and they put patients on ketogenic diets, although allowed up to 40 grams of carbohydrate per day. And I will tell you that I have been lax with some patients and saying, oh, anywhere in the 20 to 50 gram range. And a number of patients starting at that higher end never get into ketosis. So there is a reason that I now recommend that everybody just start at 20 grams or less, and then we can modify upwards if we want while we continue to check. But I usually start everybody at 20 or less. And what they found in this study, so the blue dots were patients who were able to stabilize their disease or actually maybe have a little regression, whereas the red dots had continued progressive disease. And when we look at them, both groups of patients lost weight. Both groups of patients were in a calorie deficit, but their disease status really didn't change based on that. But what we do see is that those patients who had more or a bigger change in beta hydroxybutyrate, meaning before they started the diet and then looking after, so those who had a greater rise in percent of beta hydroxybutyrate actually were more likely to be in a stable or regressed state. And when they compared the amount of beta hydroxybutyrate to insulin change, you can see that those whose insulin percent change went down, so had a lower insulin, tended to have higher beta hydroxybutyrate. And those were the patients who tended to see the benefit. There was another study that was published in 2015 discussing this idea of a glucose ketone index. And what that is it's a calculated value between ketone and glucose. So basically it's glucose divided by 18, roughly, which puts them into the same units, and then divided by ketones. So I personally like the Keto Mojo glucose meter because it will measure glucose, ketones, and calculate that number for you, and it will also keep track of your information on their smartphone app, so you can actually look at quite a lot of data. But in this study, what they found was that if you had very high glucose and very low ketones, that you tended to have continued growth of tumors. But as patients were fasted or under fasting mimicking conditions and glucose came down and ketones went up, you tended to have a much slower growth of tumor. So then they thought, well, there's got to be some calculation that we can use. And so this was then tracked using a glucose ketone index. And I'm going to show you they looked at a number of studies and calculated that. And I'm going to zoom this up. So these were mouse studies, so not people studies. But what they found is looking at different diets. So standard diet, unrestricted calories, standard diet, restricted calories, ketogenic diet, unrestricted calories, ketogenic diet, restricted calories. And if we look at the glucose ketone index, we can see that when a mouse was on a standard diet, unrestricted, their glucose ketone index tended to be higher than if they were on a calorie restricted diet. So again, calorie restriction is one way to get into ketosis. This was a ketogenic diet unrestricted, and I will comment on that. And that glucose ketone index was relatively high. And then a ketone or a ketogenic diet restricted. And then what they did is they looked at the amount of dry weight of tumor. So they let the tumor grow on this diet, and they roughly 55 milligrams, but then on this calorie restricted diet, 7 milligrams. unrestricted diet 70 milligrams, and then restricted diet 14. So you can see that there was a reduction in tumor growth with reduction in glucose ketone index. I will make a comment here because many ketogenic diet mouse studies are not truly ketogenic. They are often put on similar ratios, 80 grams of fat to 20 grams, or 80% fat to 20% carb/protein. And what has been shown in subsequent literature is that mice actually need to be on about 90% fat and 9% protein and 1% carbohydrate to actually be in a true ketogenic state. So you can see in this calorie unrestricted ketogenic diet, the glucose was actually higher. So that's not really a ketogenic state. But that being said, that's why there is one big proponent out there in the cancer world that always talks about you have to be on a ketogenic diet with calorie restriction. And I will tell you that he only works with mice. So take it with a grain of salt, but those who have learned more about what a mouse needs. In addition, these ketogenic diets the mice are on are actually full of soybean oil. So pretty terrible, and they still actually do pretty good. So in the next group, again, same thing. We had calorie restricted ketogenic diet, substantial reduction in tumor growth. Same thing in the next one. Again, when we get down into these low single digits, we start to see reduction in tumor growth. This was a GBM study or glioma study in the mouse where they did a standard diet, unrestricted, ketogenic diet, unrestricted. But you can see in this one, unrestricted, they actually still got they got better. In this, they looked at survival time, so not by tumor weight, but by survival time. So just putting them on a ketogenic diet, unrestricted calories, there was a slight increase in number of days lived. But then they did each of the diets with radiation, which is our standard of care for gliomas. And you can see that the survival time in an unrestricted standard diet was much better than either of the diets alone. But when you added a ketogenic diet to radiation, you can see, 5 times better. That's pretty impressive. They did show in a couple of isolated patient cases where they put patients on it was unrestricted ketogenic diets, but very, very high fat ketogenic diets, because you can see the ketone levels are quite high at 4.6. So an average, if somebody was just doing kind of the average ketogenic diet, they might have ketones of anywhere between 0.5 and maybe 1.5 most of the time. They wouldn't typically have ketone levels of 4 and 5. Those would typically come from a very high fat therapeutic type ketogenic diet, or with a lot of calorie restriction or fasting. So you can do some intermittent fasting and get there, or longer term fasting. I shouldn't say intermittent. It would be usually more than a day or two. But what they were looking at was PET scans. So in the initial, the patient was getting no response to standard chemotherapy, was put on the diet alone and had substantial decrease in the uptake on the PET scan. In the next thing, the same thing, FDG uptake, so the PET scan uptake decreased. And then both patients had remained in remission for a number of years until the time of the publication. Oops, sorry. And then in the very last one, the patient had an incomplete surgical resection for brain tumor, did receive chemotherapy and radiation therapy, and added a calorie restricted ketogenic diet. And it was a relatively severely restricted diet. But the patient did end up clearing the MRI evidence of disease. She really had a hard time, I think, staying on that low calorie diet, but she did do that for an additional 5 months and was disease-free at that time. But then after she resumed her regular diet, she ended up having a tumor recurrence about 3 months later. So was that going to happen anyway? We don't really know. But there is, some level of interest in saying this might actually be of benefit. So there's a couple different ways to do this. Sorry, I'm running late. I'm talking too slow. Typical ketogenic diets tend to be about 70-30 or 1-to-1 in amount. So maybe 1 gram of protein to 1 gram of fat, which turns into about 70-30. There are more therapeutic diets where you increase the amount of fat, decrease the amount of protein and carbohydrate. You can do that. I usually say make your food shine. So you're just dousing vegetables or salads in olive oil, like maybe you're even eating fatty sauces like pesto sauce or other rich sauces on your protein, maybe eating the fattiest cuts of meat like pork belly. Maybe you're adding more egg yolks to your meals, maybe adding even fatty coffees. So that's where fatty coffees have come in. It is not I would never recommend it for kind of a standard ketogenic diet per se, but I think if you're trying to truly do a therapeutic ketogenic diet, there can be some benefits. But even though these ratios are great, I usually just say use your ketones. Like if your ketones are too low and you want to boost those higher, then you have to maybe up the fat or maybe increase the calorie restriction or do more fasting. So again, if you have weight to lose, well, then do some more fasting, do some more calorie restriction. But if you don't have fat to lose, then you really need to push your fatty intake. You can consider even adding some exogenous ketones. Very limited data in people at this point, but there is some laboratory data that when we add exogenous ketones, we further push glucose and insulin down. So that is a possibility. But then we have to tend to all of our other lifestyle factors. Exercise, which can help reduce glycogen stores, make more room for glucose, make us more insulin sensitive. Strength training increases our muscle mass, gives us more room to put sugars. But stress reduction, stress is a big one. Stress raises my insulin. So be aware that other things can affect your insulin. Getting quality sleep. We know that interrupted sleep, shift work, all of those things that really disrupt your circadian rhythm will increase insulin as well. Working on breathing through your nose as opposed to mouth breathing, getting good sunshine and vitamin D, and looking to eliminate as many toxins that are in your environment. I always recommend the book Estrogeneration, but also the metabolic approach to cancer has a lot of guides on toxins, etc. So that ties it up, and I will open it up to questions, and I will just share that yes, the new business is starting to rock and roll, and available to all of you if you need some additional help or guidance.